So most of us, when we plan the ICL surgery, there are two things we are afraid of. One is cataract and another is glaucoma. So we'll discuss each of these. First, coming to cataract after ICL surgery. So there are two main reasons for cataract formation after ICL surgery, which we have learned from our experience of last 15 years. First is ICL crystalline lens touch, and the other is excessive irrigation or irrigation fluid jet hitting the anterior capsule. So first we'll discuss about the one which most of us are aware of and afraid of, that is ICL and crystalline lens touch. So this is how a normal vault, ICL vault in the eye should be. The vault is a space between the back of the ICL and the anterior capsule of the lens. Normally it is 500 microns plus minus 250 microns. Here it is almost 500 microns. It is measured by comparing it with the corneal thickness, which is approximately 500 microns. We need a good ICL vault so that it allows for the movement of the aqueous humor. If the vault is very less, it causes aqueostasis, which can lead to the formation of cataract. So this is a case we did around 15 years ago of minus 30 diopters. We did bioptics for him and we implanted an ICL for him. That was old V4 model, that is ICL without holes. So this is how his vault was. The vault was very shallow and there was an ICL crystalline lens touch. So at that time, we didn't have much experience and we thought whether we should exchange the ICL for a higher size or shall we continue with the same and observe the patient. So we decided that we will continue, we will not exchange the ICL and we'll just wait and watch. For years, it worked very well. The patient was following up with us on yearly basis until in the 5th year, he developed a small speck in the periphery. So again, it got us thinking, shall we exchange it or shall we just observe? So since the cataract was peripheral and it was not affecting the vision and it was very small, we again waited and followed up the patient. So it worked very well for 10 years until in the 10th year, the patient developed a central cataract and we did the ICL surgery. So through this case, the message I want to give is that with the ICL crystalline lens touch and that too with the old V4 model, it worked so well for 10 years. We didn't need the cataract surgery for 10 years. So coming to another similar case, this is another case of cataract with old V4 model without holes. There is a speck again in the periphery as seen in diffuse illumination and slit lamp illumination. This also occurred after 5 years of ICL implantation. So all these cataracts occurred with old V4 models only. Since 2014, since the time we have started using V4C model, that ICL with holes, we have not encountered a single case of cataract, even with such low vaults as this. Here the vault is less than 100 and still we are following up the patient and there is no evidence of cataract. So this is how we counsel a patient who comes and asks us about the risk of cataract after ICL. We tell them that the cataract used to happen in early V4 models. It doesn't happen anymore with the newer V4C models, that is ICL with hole. There are several studies on zero incidence of cataract in last 5 years. The incidence of cataract is as low as 0.1%. And we tell them it is almost safer than going out on the road. So if the advantage of implanting ICL is huge and the risk of cataract is minuscule, then this risk is worth taking. And even if in the rare situations cataract does happen, it can be managed 100% with the cataract surgery. There is never any loss of sight. So now coming to the next reason, which most of us are not aware of, is excessive irrigation or fluid jet hitting the anterior capsule. Not much have been reported about this in the literature also. So These are the pictures of first post-operative day after ICL insertion. We saw the white deposits on the anterior capsule of the lens. It appeared like a membrane on the diffuse illumination, and this is how it appeared on the retroillumination. These deposits decreased on the follow-up, and by 3 months they were almost not there and the vision was not affected. We thought that these white deposits were the retained viscoelastic material, which cleared on its own with time. We saw 3 to 4 such cases in a short duration, and we thought that if retained viscoelastic is the problem, then why not stop using visco and start using hydroirrigation for ICL implantation? So we started hydroimplantations. So after starting hydroimplantations, almost 3 months later, we saw another case of such white deposits on the anterior capsule. We were using the viscoelastic of a very small amount in the injector only to load the ICL, and we thought how such minuscule amount of visco can deposit on the ICL and can be retained. So we thought about it, but we didn't get any answers until after 1 year we got another case with huge amount of deposits on the anterior capsule of the lens. This time we checked up the literature and we came across a case report which talked about vacuolar changes on the anterior subcapsular space of the crystalline lens, which developed after the irrigating procedure through the narrow space between the ICL and the crystalline lens. So these white deposits were actually the vacuolar changes that happened on the anterior capsule of the lens, and this was not the retained viscoelastic material. And on OCT, ASOCT, these vacuolar changes appeared like bleb-like lesions, and these were transient. They gradually improved with time. So we also started doing ASOCT for all our patients, and I'm showing you a case which was very severe. Here you see the vacuolar changes on the anterior capsule of the lens, and this membrane here, these vacuolar changes organized here to form the membrane. So this was the most severe case we saw. So what we conclude from this is that visco has no role in inducing subcapsular vacuolar changes or cataract. The excessive irrigation can cause transient anterior subcapsular vacuolar changes on day 1, which improves with time. And the most important message which we learned from this is that during hydroinsertion or visco removal, do not irrigate under the narrow space between the ICL and the crystalline lens. Because when we go beneath the ICL, the space is very narrow and it hits the anterior capsule and bring about these vacuolar changes. And even if you do the irrigation flow and irrigation time should be very minimal. If we have Centurion or other machine, we can try the low IOP settings, or we can keep the bottle height low so that the irrigation flow is lower. So coming to the next concern, that is glaucoma after ICL. So there are 3 main reasons for rise in IOP after ICL insertion. First is residual visco, the second is high vault of the ICL, and third is ICL placed upside down. Coming to the first one, the residual visco, if there is a retained visco, it clogs up the trabecular meshwork channels and causes the immediate rise in the post-op period, which needs anti-glaucoma agents for a couple of weeks until the visco gets washed away. Now the next and a very important cause for glaucoma is high vault of the ICL. Generally we say that the vault is high if it is more than 1000 microns. So what do? If the vault is high, we follow up the patient with the IOP monitoring and we check the angles on gonioscopy and ASOCT. If the IOP is normal and the angles are open on gonioscopy and OCT, we wait and watch. But if the IOP is raised or angles are closed on gonioscopy and ASOCT, we exchange it to the one size smaller. I'll discuss both the scenarios. So this is a case of high vault. The vault is almost 1400 microns, but ASOCT shows that the angles are open, and the IOP for this patient was also normal. So we are waiting and watching, and we have followed up the patient for 6 months. There seems to be no problem. And there should be no hurry in exchanging the IOL, because the normal vault of the ICL also decreases with time. Generally, the vault decreases by 30 to 40 microns per year. Okay, but in this was a very unusual case. In Feb 2021, the vault was 1583 microns. After 1 month, the vault fell by 100 microns to 1484. After 8 months of follow-up, it decreased by almost 170 microns to 1316. And last month in April 2022, the vault was 1200 microns, that is less by 370 microns from its original vault. Though it's an unusual case and we still don't know the cause. But we shouldn't hurry up in exchanging the ICL if the IOP is normal. Now, so when do we exchange the ICL? When we have very high vaults and the IOP is high, we exchange it. So far, we have done 3 cases of ICL exchange because of higher vaults. So here is one such case. Here, on ASOCT picture, you can see that the iris is almost touching the cornea in both the eyes, and the angles are closed. And the vault was so high that we saw ectropion UVA. The ICL was pushing the pigment epithelium from behind. So we put the patient on the anti-glaucoma agent, and we decided to exchange the ICL with the smaller size. So you can see the AC is very shallow, and there is hardly any space for even side port entries. We used up the same side ports and the main port because the surgery was done immediately within a week. This is so shallow that the side port is hitting the iris. Normally exchanging ICL is not that difficult, but with such high vault, we had quite a struggle in taking this out. Now we generally, normally we take out one of the haptics out in the anterior chamber and then we pull out from the eye. But here we were struggling to bring out one of the haptics, but we were unable to do so. So we somehow managed to grab one edge of the ICL here and we pulled it out directly from the eye. And exchanged it with the smaller size. So this is how the vault was after the exchange. The angles were open. So last but not the least, this is the case of ICL placed upside down. We didn't have any of our cases. This was presented by Dr. Sanjay also. This case was done elsewhere and the patient presented to us after 4 years. So when we saw the patient, the IOP was high, the AC was shallow, and there were a lot of anterior synechia. The CD ratio was 0.7, and we decided to bring out the ICL and exchange it with the smaller size. We even tried to break the synechia, but it was so strong that we couldn't break all the synechias. So now we are following up the patient. The vault is normal, the IOP is also normal, but the patient is still on anti-glaucoma agent. Thank you.
And there was no cataract in this eye?
Yeah, and there was no cataract in the eye.
Oh yes, anything. All these strong viscose or Helon, GVS, they would be the best thing because everything is so tight inside, the iris is all stuck, all 360 degrees. You really need a very open chamber to work in the AC.
For 4 years, it was upside down, no closing any cataract, even no glaucoma in the ear.
No, glaucoma was there. Yeah. No, I don't know when it developed, but the patient was on glaucoma treatment for a long time.
But the,
No, there was a little variation. It was corrected, but there was a little variation. Yes. We could, but this was without the hole. So we took it out and replaced it with the one with the hole. Yeah, yeah, you can flip it aside. Yeah.
ये connector निकालना?
No, you should bring it out. Turn it around and then put it in. Otherwise, you will rub against the whole endothelium and you will also rub against the lens. You will injure both the tissues. No, that high vault was ours only. It was obvious, but now that we have put the lens in and it was in position, we thought let us see what happens. How do you tell the patient that bhai maine lens nahi dal paya? Very difficult situation, na? Your sulcus, what we do is white to white. White to white has no relation whatsoever with sulcus to sulcus. So you can have any variation. It's a different tissue. With only with UBM, no? White to white is the simplest way to put an ICL. If you have the other measurements, it's even better. A sulcus to sulcus is naturally ideal, but then it depends on how you acquire the data. And again, in the acquiring process, there can be a lot of variation.
What would be the reason of decreasing what with the passing of the years when the lens size is increasing?
So lens size has got nothing to do with the position of the ICL. ICL is in the sulcus. ठीक है ना? So ICL is not going to go up, na?
Vault is between the ICL and lens.
The vault is between the ICL and the lens. The lens will grow with age and the vault will decrease. It is not necessary that the ICL is coming down. But that growth of the lens is normally 20 microns a year. But this happened, how much? 300, 400 microns difference in 1 year? I still don't know why it happened. It was just a matter of chance that we are doing ASOCTs every visit. And one of our doctors said, कि, sir, ये देखो ये तो vault खुद ही कम होते जा रहा है. And we really didn't have an answer. It depends how the sulcus there is. Because again I said, normally we say the white to white is maximum horizontally, less vertically. ये तो है ना? The cornea is not round, na? It is stretched like this. So it should also follow that the sulcus should also be stretched more like this and less vertically. But then the vault should increase if you take it vertically. But many places it has been documented that take it vertically and the vault decreases, which further goes to prove that the vault to vault has no relation to sulcus to sulcus. It has no relation to sulcus to sulcus. No? Angle to angle still has a relation to sulcus because both are uveal tissues. But white to white has absolutely no relation. It's just that it works in 99% of the cases. Only if there's a tricky situation. If everything is fine, the patient has come and we just see everything is fine, go back, यार. जितने इन्वेस्टिगेट करोगे उतना सस्पिशियस होगा कि पता नहीं क्या हो गया मुझे. कहेगा डॉक्टर साहब सब कुछ ठीक तो है ना? With the best of result, you are putting suspicion in his mind. हाँ सब कुछ दिख जाता है, वैसे दिख जाता है. Vault is almost the size of the thickness of the cornea. Cornea thickness is 500 microns. The vault should be 500 microns. So the slit the size thickness of the cornea should be the amount of vault, plus minus 250 microns. Hmm? Nothing really. That's why it's safe. There's actually nothing.
With 1000 volt, if the patient is comfortable, no issues, can we just observe?
I showed you 1500 volt and we didn't do anything. 1500 is unimaginable. Anything over 1000 we say is very high. Now people are saying that 1000 is the real volt. You should target at 1000. Why? Because the lens is going to increase in size 20 microns every year. In 5 years, it has increased by 100 microns. It's got 100 microns closer to the ICL. In 20 years, it has got closer by 400 microns. And then one day, everything will start touching the ICL. पता नहीं अब कैरेक्टर कब आता है उसका?
I just wanted to ask, which is the oldest patient who has received ICL in your experience?
18 years. But the oldest ICL done.
Oldest, matlab the patient's age. What was the
Age oldest?
Age? Yeah, 40 years, 50 years, 60 years. Like at what age? What is the oldest patient who received an ICL? And secondly, are there any?
Our general concept is that if at all a person, if he has to have cataract at 70, he may get it at 60. Because ICL is still a 19-year-old technology. So if you put an ICL at the age of 25, so that guy is still about 45. So where does that data come in from?
And oldest patient who received ICL?
I think something about 60.
60 years with a clear lens?
People give a cutoff at 45 years.
Okay.
So they say.
Sir, can you tell us the exact name of the instruments which you use? The two instruments which you use?
So, okay. So the two instruments, one is that alligator forceps. And now some of that is the original star model which has been going on for 15 years. But it's a little big, and many times when you try to catch it, it keeps pushing the lens behind. So we have designed another new model, which is with the epsilon, which is a little shorter and a little wider, because a big grip is good grip is important, and you should just go and catch. Not that you're holding it and it slips further, hold it, it pushes back further. So that is available now. Probably in this exhibition, they may not be displaying it because we just finalized the design about a month back. But you've been using it for almost 6 months now, testing it. You talk to them that we want Dr. Chaudhary's design and they'll give it to you. And then there is this manipulator. That also was a thicker manipulator. We have just cut it down to make it a little thin so that it's easier to manipulate within the eye. So that's just a regular manipulator. My ICLs, something over 5,000, I guess. Again, you will get it by the person who provides you with the ICL. If it is genuine, you have the pictures, you give it to the company and they'll do it. They have that much of a margin, star people, the dealer.
The explantation forceps is the regular IOL explantation forceps, or how do you pull it out?
No, I use what is called a IOL cutting forceps and scissors. They have a better grip. So I use a one which is from Indo-German. That of all the forceps I have experimented, that has the best grip. Crocodile is the one which I showed you here, na? That also works, but its grip is not so good. But let me thank everybody. Thank you for such a patient listening. It was a pin drop silence, so it was very encouraging. Everybody was tuned in. Thank you.